Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about Vyleesi. Vyleesi, or bromolanotide, was approved by the Food and Drug Administration in June of 2019. It's the second drug that's been approved for treatment of hypoactive sexual desire disorder. The first one was ADDI. So this is generalized disorder, all partners. It's acquired. You used to have sex urges, now you don't. And it's for women who have a decreased sex drive that causes marked distress or interpersonal difficulties. It's not just that you don't have any interest in sex, it's that it causes some kind of a difficulty. It works to stimulate a receptor in the brain known as the melanocortin receptor. There are several different types, and it seems to work most on the type 4 receptor, but it has some activity against the type 1 receptor, and why that's important we'll see in a moment. It's a simple chemical. It's 7 amino acids. It's meant for subcutaneous administration, just like insulin. It comes as a single-dose auto-injector meant for you to inject either in your abdomen or on your thigh about 45 minutes before planned or anticipated sexual activities. The medicine lasts for about 8 hours. And with time, a woman decides when is the most appropriate time to give herself a shot. Comes as a carton of 4 auto-injectors. Each injection has 1.75 milligrams of the active ingredient. You're not supposed to take more than 1 dose in any 24-hour period, not more than 8 injections per month. And if you've used the medicine for 2 months and it doesn't seem to work, then you ought to stop it. Now, unlike most medicines that you can go to the corner drugstore and get, this has to come from a special pharmacy. Can't just very easily get it. Well, if you do have the medicine, as with any other kind of an injection, you should look at it, make sure it's not cloudy or has any kind of particulates in it, or that it's not discolored. That's very important, obviously. And the medicine will not enhance sexual performance. It's not for men and it's not for postmenopausal women. So the studies that were done were about half-year long. And on average, the women were about 39 years of age, ranged from about 20 to about 55. 85% of them were Caucasian, 10% were African American. They were told not to use the medicine more than once a day and not to use it more than 12 times a month. So how often did the women use it? They had it readily available. They chose to use it only 2 or 3 times a month. None of them used it more than once a week. And on questionnaires, to detect whether their sexual desire increased, well, it did by a tiny bit in 25% of the women compared to about 17% of the women receiving a placebo. So that's no great shakes. And did it decrease the distress score? Well, yes, in 35% of the women versus 31% of the women receiving a placebo. And there wasn't any difference from the start of the study to the end of the study in the number of satisfying sexual events. And there was no increase in sexual performance. And these women had been in long-term monogamous relationships of about 12 years duration. They had their condition, this HSDD, Hypoactive Sexual Desire Disorder, for about 4 years, and 70% of the women had a decrease in arousal. Well, the mean number of injections they used over the course of 24 weeks was only 10. And in the open label study that lasted a year, they only used 12 injections. Interestingly, the studies were funded by the drug manufacturer, Paladin Technologies, and several of the authors of the paper were employees of the company. But UCLA did a study. And they evaluated some of these drugs that are used for so-called hypoactive sexual desire disorder. And as a matter of fact, what they found was the drugs, if they were better than a placebo, it was only minimally superior. And that's drugs like ADDI and Vyleesi and Aspina and intranasal oxytocin and Wellbutrin. And the discontinuation rate was about 18%. Now get this, you give yourself a shot, and 40% of the women are going to become nauseated, and 13% of the women are going to require an anti-emetic so they don't vomit. Usually lasts for, comes on in the first hour and lasts for about 2 hours. Fortunately, it seems that recurrent injections are less often associated with this condition. Well, some of the women develop a cough or fatigue or hot flashes or numbness and tingling about the extremities, sometimes, rarely, some musculoskeletal pain, some arthralgias. There was one person who developed a chemical hepatitis without any other explanation other than the medicine. Sometimes people become flushed. Actually, one person was hospitalized. But now remember I said it also works on the melanocortin-1 receptor. Well, that causes darkening of the gums and the breasts and the exposed skin, especially in darker skinned individuals, and especially with more frequent use. And worse yet, it seems not to subside after you stop using the medicine. And for some women, it causes a transient, small but transient increase in the blood pressure and a decrease in the heart rate that usually returns to normal in about 12 hours. But it certainly means that you shouldn't take it if you have cardiovascular disease, and you should make certain that your blood pressure is normalized before you take the medicine. And you probably shouldn't drink alcohol when you take the medicine, and you should avoid taking naloxone for either alcohol or opioid dependence. The medicine seems to be able to slow the gastric emptying, and that decreases the absorption of oral medicines like Lasix or Indocin or Wellbutrin or Sartan that you would take for your high blood pressure. Seems to work on the melanocortin receptors inside the brain, and they're somehow associated with sexual arousal and, interestingly, with appetite. The melanocortin type 4 receptor, that seems to be the most important one, and they have receptors on brain cells that are scattered throughout. Now, once you receive the injection, the maximum concentration in the bloodstream is going to occur in about an hour. The bioavailability is 100%. Only 20% is bound to plasma proteins, which means 80% is not, and it's the not portion that seems to be active. The half-life of the drug is about 2.5 hours, range anywhere from about 2 hours to 4 hours. It's a simple peptide, as I mentioned, with only 7 amino acids, so the way the body metabolizes it, it just hydrolyzes it. It just breaks some of the bonds. It's excreted, 2/3 of it in the urine, the rest of it in the feces. Probably shouldn't use the medicine if you're pregnant. You should use a contraceptive if you take the medicine. In animal studies, it caused fetal harm, or at least the potential for fetal harm at high doses. Women who were taking the medicine were supposed to be taking contraceptive so they wouldn't become pregnant. In spite of that, 7 women became pregnant on the study. 1 had a spontaneous abortion, 1 was lost to follow-up, and 5 women had normal births. In practice, however, birth defects occur in 2 to 4% of the general population, general associated with pregnancy, and miscarriages occur in about 15 to 20% of all pregnancies, irrespective of the drug. We don't know whether it has any effect on breast milk, but certainly women who are breastfeeding shouldn't be taking the medicine. Doesn't seem to cause any interaction with poor kidney function. If you have moderate to mild liver dysfunction, that's okay, you can use the medicine. Doesn't seem to be carcinogenic or mutagenic, doesn't seem to impair fertility. Well, the interesting thing is that drug companies funded studies that showed that about 1 in 10 women, 10% of the population, complains of sexual issues. The drug company thought, well, maybe their drug would be appropriate for about 6 million women. Claims the condition is under-recognized. The 1992 National Household Survey of Adult Sexual Behavior, well, it found that in women between the ages of 18 and 59, about 43% complained that they had some degree of sexual dysfunction. But when they sort of said, well, you have to have at least a moderate or marked amount, then the percentage decreased to only about 12%. Now, it's interesting to note that many of the papers dealing with hypoactive sexual desire disorder are written by the same people. If we look at hypoactive sexual disorder in women, we find that there are several different subcategories of female sexual dysfunction. HSDD is one of them, arousal disorder is another, orgasmic disorder is another, and sexual pain disorder is yet another. Now, what's the definition of hypoactive sexual desire disorder? It's low sexual desire that causes marked distress or interpersonal difficulty. And it's not secondary to some other kind of a medical disease, a psychiatric disease, not due to depression, not due to problems with the relationship, and not due to medication or substance abuse. It's acquired, so you weren't born with it, and you started off enjoying sex or having sex. It's generalized, so that means that it doesn't relate to just your one partner. It's no interest in anyone. But, you know, this is not a universally accepted concept. Some argue that HSDD, or the Hypoactive Sexual Desire Disorder, is not really a medical condition. But here's the problem. In 2012, the FDA identified female sexual dysfunction of one of 20 disease areas that should be high priority and they should focus their attention on. So in 2014, they had a two-day meeting, and the two-day meeting was to advance the understanding of female sexual dysfunction, and that led to the FDA in 2016 issuing guidelines for developing drugs in this particular area. Now, interestingly, the FDA no longer requires that the company test the drugs for low female libido to actually see if the women were having more sex. Interesting reasons behind that. They've been under pressure for years at the FDA to encourage more options for women who have low sexual drive, because they point to Viagra for men, and they say, geez, if a man can get an erection when he uses Viagra, why don't you make a similar product for women? Well, the answer is that the chemistry is completely different. So, for some reason, the American Psychiatric Association got involved in all of this. And in their DSM-3, Diagnostic and Statistical Manual, that's the Bible of all psychiatric diseases, 1980, they listed inhibited sexual desire disorder. And that was in the DSM-3. And that also referred to sexual aversion or sexual apathy. And informally, that was where the term frigidity arose. Well, then, in their revised edition in 1987, they changed it to hypoactive sexual desire disorder. And they said it could involve 20% of the population. And they added sexual aversion disorder, sexual apathy. So they keep changing the names, changing what it means, changing the definition. Well, in 1994, they did it again. They came out with the DSM-4, and then they revised it. And now we had not only the hypoactive sexual desire disorder, but we also had female sexual arousal disorder. And then they changed again in 2013. They substituted both of those for the female sexual interest arousal disorder. And they said men could have it too. And the American College of Obstetricians and Gynecologists, they said, yeah, it's a disease. But some asexual individuals who have no interest in sex say, hey, we don't have any disease. We're just not interested in sex. So the acceptable libido seems to be socio-culturally influenced or defined. And interestingly, all of the doctors who were on the panel that defined what HSDD was were consultants or members of an advisory board to some of these drug companies that make the drugs that they're talking about. So to some extent, your sexual desire is shaped by life's experiences. What kind of maladies you have, what kind of medicines you take. Do you have low thyroid activity? Do you have diabetes? Do you have depression? Maybe you're taking a birth control pill. Well, interestingly, the executive director of the National Women's Health Network, she urges the people should avoid taking these kind of drugs until more information is available regarding their safety and their effectiveness. And interestingly, of course, female sexuality has a lot to do with significant areas of brain chemistry. So it's not just the melanocortin, that might be important, but so too is dopamine and oxytocin and vasopressin and adrenaline and prolactin and testosterone and serotonin and the endogenous opioids and even the endocannabinoids. So Vyleesi, it was developed in by the company known as Paladin Technologies. They licensed it in 2017 to AMAG, That's a pharmaceutical company in Waltham, Massachusetts, just outside of Boston. They paid them $60 million when the FDA approved it, and they're paying them royalties on the annual sales in the high single digits, low double digits. And they're paying them milestone payments when the sales reach $25 million, then when the sales reach $250 million. But the drug's going to have limited appeal because it's probably not going to be covered by insurance. Now, Addy, the original drug in the field, well, that was manufactured by Sprout Technologies. There was an intense lobbying effort by Sprout to get FDA approval. Actually, it was rejected twice. Then finally, Sprout framed the whole issue as a women's right issue. And then as soon as the FDA approved the drug, they sold it right away to a company out of Canada known as Valeant for $1 billion. And the sales were dreadful. And basically, the company in Canada, Valeant, they just basically gave it back to the people who originated the drug. They said, here, you go try to sell it. Because one thing is, it was expensive, about $800 a month. The other thing was, it wasn't all that much different than a placebo. And then it had a black box warning saying, don't take it with alcohol, because you could have a dangerously low blood pressure and you might faint. Well, the company did some new studies, of course, and the new studies show, well, maybe it isn't so bad. So the FDA softened their warning in April of 2019. Now the company has an advertising campaign. It's the right to desire. But Vyleesi, they have one too. They have a public relations campaign, and it's called unblush.com. That's a site sponsored by Amic Pharmaceuticals. But they don't tell you the price. And you know the drug is very expensive. So what's the outlook for Vyleesi? Is it really going to cure this hypoactive sexual desire disorder? I don't think so. I think the chance of this drug being successful is very low. And that's at best. And remember, according to UCLA, drug doesn't seem to work very well. It's not a home run. And don't forget, there's a major question regarding why the medical profession, in this case, mostly male psychiatrists and gynecologists, chose to label low sexual interest as a medical disease in the first place. So just be cautious about this drug. Anyway, thanks for watching. Hope you enjoyed the show. If you did, please tell a friend. Consider subscribing so that you'll be notified when we post new videos. Appreciate your interest. I'm Dr. Ken Landau.